Fantastic. Good afternoon, everybody. Well, thanks for joining us here today on this Facebook Live. So I'm Dr. Alamanda. I'm one of the hip and knee replacement specialists here at OrthoVirginia. And thank you guys for coming along for this ride. We'll be chatting about robotic joint replacement today. And, I like this to be more of a Q&A sort of session. So Leanne is also our fantastic marketing person who's on the other side of this, making it happen. So thank you to her for making it happen today. But, send us your questions. She will type them up for me. And as we go through the presentation, I'll either answer them as we go along or we have a good amount of time for Q&A. So essentially, it's going to take us about 10, 15 minutes for a presentation. And then the rest of the time is essentially open session. All right, fantastic. So why does joint replacement matter? I always tell patients, two things. Arthritis only gets worse. It never gets better. By that same token, nobody dies from arthritis. It's quality of life. So ultimately, we get to decide, and you get to decide if and when the time is right for surgery. Basically, what happens is what arthritis is a loss of that cartilage, right? So the meniscus goes away, and then over time, you can see the cartilage starting to thin down a little bit. And as the cartilage thins down, then the bone starts getting exposed underneath. That's when you start getting deformities happen. People get bow knees, knock knee. The knee doesn't go fully straight, things of that nature. And I love doing what I do, which is hip and knee replacements, because, it's not heart surgery, but it does give people back their life. Quality of life becomes restored. The mobility becomes restored. Patients love it for that aspect. And as surgeons, we're always looking to see how can we make a great operation even better. And in my mind, I think technology is the way to make it very precise. It takes the guesswork out of the equation. All right. So next slide, please. So what a robotic knee replacement is, and we'll chat about the hip as well next, is the way it helps me with is it helps me assess alignment and ligament balance. So we're not guessing anymore. I know exactly what degree it is that we're starting off with and what degree it is that I'm ending with. I know exactly the assessment of the ligament. There's no subjective feel. It becomes much more precise. The other advantage is that it makes it as personalized as you can get it, right? Each scan is developed just for you. In fact, the planning is done before the patient even gets on the operating room table. We get to know exactly how the implant fits the bone and what it looks like prior to any cuts being made. So it allows for very minimal bone resection, allowing you to keep more of your own bone, and supports very personalized and individualized knee reconstruction. Next slide, please. So, similarly on the hip, the biggest issue with the hip is two things. One is leg length and offset, and the other thing is cup position. These two things are things that are very easy to sort of create deviations in. Especially with the cup, we want to make sure we put them in the right spot, and the robotic platform allows us to do that. It sort of helps us to put the cup in exactly where we want it to go. It also gives us a tremendous look into leg lengths down to 1 millimeter, and also offset. What offset is basically how far away is the leg from the center of the pelvis. So it allows us to do that. It makes sure everything is consistent. The other advantage of doing it this way is that we are no longer guessing. We're not depending on muscle tension to assess leg lengths. It's precise to 1 millimeter. We take a measurement before we start the operation, and we take a measurement after the trial devices are in to know exactly how much we change it by. And one of the advantages of these newer robotic platforms is we can actually take the hip and the knee, mostly the hips, to a range of motion with the implants as if they were put in, and seeing where they're impinging, so that we can then modify the position of the implants to reduce risk of complications like dislocations and stuff. And that it makes the surgery much more accurate and much more precise, and lets you get back to doing things that you want to do in a quicker fashion. Next slide, please. So, this is the title of the talk, which is the top 3 things. So this is my opinion, and I'll tell you why I think robotics is very helpful. Number 1, it makes it precise. So I always tell patients, you need to know a target, and you need to know how you're able to hit the target, right? So knowing the target is one, that's where the 3D modeling and all that allows it to happen. And you have to consistently hit the target that you set. And that's where precision is, right? And so precision is delivered near 100% with robotics. We can sort of exactly get to where we need the target is and make sure we attain the target through robotics. The other thing is personalizing the operation. Before robotics, we would open sizes 1 through 10 for anybody and have them all available. But now we pretty much know exactly the size that we're aiming for before we even start the operation. We're very close to what we plan for, maybe a size up or down, but pretty much exactly spot on, partially because of imaging that we get as part of the preoperative workup as well. And the biggest takeaway that I think people should know is some of the misconceptions people have. It is a tool after all. If you use the tool the wrong way, it can mess up, right? So you got to know how to use the tool. And it's a tool to assist us, not to replace us. We are still doing the operation. We are still sort of doing the things that we want to do. So next slide, please. So how does it improve precision? So a lot of it is just like homework. You don't go to a test unprepared. You study for it beforehand. You do the stuff beforehand, and half the battle or more than half the battle is over before you even start the quiz. And the same thing happens with surgery as well. We get a CT scan of it before surgery of the body part. We develop, then using that 2D pictures, we develop a 3D model of your own arthritic joint. And then that plan then gets fed into a computer platform that then allows us to convert that into a surgical plan where implants are then overlaid onto the knee or the hip. And then we fine tune the adjustments based on your ligaments and sort of tension and stuff like that during surgery. But really 25-30% is done during surgery. 75% is done before surgery. And then all that is to say that leads to you have a fantastic recovery. It gets you moving along quicker and getting you to where you need to be. Next slide, please. This is what we talk about personalizing it. We use your own anatomy, right? We personalize it based on your size. In fact, these acetabular, which is the socket side of things on a hip replacement, come between every 2 millimeters of increments. And 2 millimeters is about the width of 2 hair strands, essentially. So it allows us to create a very specific surgical plan based on your anatomy. We know the exact size, and we're able to ream for the exact size and take away very little bone. So we don't create unnecessary defects or anything like that. We just go in, do what we need to do, take out the cartilage that's gone, and reconstruct it by preserving as much of your own anatomy as we can. And most of that is sort of based on the input that's from the scan that goes in before the surgery. This is the most important thing, as I've mentioned before. It does not replace us. We are able to remain in complete control. And there have been cases where we question the robot once or twice in a year, and we get an X-ray to confirm, and it provides data and guidance. It's data in equals data out. So we're still, we as surgeons still have to be happy at the end of the procedure to make sure that the patient has a stable joint, the alignment is restored. But I tell patients, just like you would use any tool, just like you use a screwdriver to put a screw in the wall, this robot does the same thing. It's just a fancier screwdriver. We're still turning the screw to get it in the wall. So we sort of use our judgment in the operating room to determine if we've achieved what our targets for the surgery is. And I think that's very important. People often think sometimes, we're out there drinking coffee in the cafeteria while the surgery is being done by the robot. That is not what happens. It is a tool that is being used by us to control the surgery in a very accurate manner. So, I was thinking, I was thinking about what questions people usually have. And, these are some of the most common questions that people ask me in clinic. And so one of the questions that patients ask is it safer? And, robotic surgery, there's good data on the literature to show that it's safer. We don't spend any more time with using robotics in the operating room, especially if we use it routinely like we do, and things of that nature. It doesn't add to any more operative time and no more increased blood loss. In fact, you can make the argument that it leads to less blood loss because you're not exposing as many things, and you're not, going into intramedullary canals for alignment purposes. So it does, in my mind, make it a safer operation. A recovery, there's definitely theoretical benefits of doing it with robotics. You're not, again, going back into the canal, so there's less blood loss and things of that nature. Hurt less is more of the overall procedure. You're not opening up a lot of things. Your exposure is not as extensile, and that allows less damage to soft tissues and things of that nature. Who are candidates? Most patients are candidates for robotic hip replacements or knee replacements. Only a rare certain cases where they're not good candidates. Usually if they have extensive hardware in that distorts the anatomy, that we have to use other techniques for. There are big revision cases that we do that it's a little bit too advanced of a surgery, to be honest, for the robot to tackle. Those are sort of, things where a robot sort of does not have its limitations. So we certainly try to do what we can and try to get, the goal is to not use a robot or not to use a robot. The goal is to get the patient their desired outcome at a faster, quicker, and a more efficient level. And if the robot lets us do that, so be it. And that's how I view this tool. So, like I said, I want to make the presentation brief. Last thing you want is your stuff that you can probably watch in a YouTube video. But I want to really open it up for Q&As because people ask interesting questions. And I think, other patients and other people will also sort of say, oh, wow, I didn't think about that kind of stuff. So I see a bunch of questions coming up. So I'll start going through them in a bit. But again, the key takeaway is robot is an asset. It's a friend, not a replacement. It allows me to deliver precise, personalized surgery, but that's where I'm still in control. So I still get to control the finer details, where it helps me achieve my target. And like I said, going back to my analogy, just think of it as a big fancy screwdriver. You can still put the screw in by hand, but it just makes the job a whole lot easier using a screwdriver. So with that, I'll open the floor for questions. I think we have another 15 minutes or so in this presentation. So I'll go through as many questions as we can. If you don't, please feel free to type them in and I'll get to see them as they come through. Okay, so one of the questions that I was asked was, how soon can someone get a knee replacement? And I'll tell you that that's really a question that you decide with your surgeon. Usually the sort of what I tell patients is when you wake up every day and you think about pain as the limiting factor and what things you cannot do because of the affected joint, that's when you sort of think about getting it replaced. I always joke to patients, we don't treat x-rays, we treat patients. So everybody's different. I've certainly had patients who gotten to surgery at a quicker scale, and patients who have bone on bone, and they're able to sort of carry along with life without significant issues. So it's very, very patient factor dependent. Did you cut muscles or other tissue? So our goal is to make it as least invasive as we can. Obviously with the hip and the knee, they're both deep joints, meaning they're superficial. They're not superficial. So we try to minimize the damage to soft tissue, and robotic allows us to do that because our exposure doesn't have to be as extensive anymore. So we sort of keep it as minimally invasive as we can. And again, the goal is to get you back quicker. So if those are not, if they don't allow you to get quicker, we're not going to do that. So that's that. Somebody else asked, how long does surgery last? So a typical surgery takes us about 45 minutes to about an hour and a half or so. So 45 to 90 minutes of surgical time. But, I always tell patients it takes more time than that just because we have to get the patient ready for the operating room table. There's a lot more time that goes involved in positioning. As with anything in life, I think preparation is what leads to success in the operating room. Be that preparation before the actual surgical date or preparation before the surgery actually begins. Making sure we sort of, get the robot prepared, get the robot covered appropriately, sterilely, make sure the patient is prepared sterilely. So the whole thing takes us about 2.5 hours or so. But the actual surgical time is about sort of 45 minutes to about 90 minutes or so. So what's the difference between robotic knee replacement and non-robotic knee replacement? How do you choose which to get? The implants, or believe it or not, are actually the same. Doing it robotically is just like going back to the analogy. The screw is the same screw. If you put it in my hand, or if you put it in a screwdriver, it's the same screw. It's just how you choose to get it in, right? The robot, think of it as a tool that allows me to get the job done, for me at least, more accurately, more precisely, and without significant deviation. What I choose for most patients, my go-to is robotic. The few exceptions are if they are not a good candidate for robotic because of implant-related issues, meaning they have prior hardware in, or there's some artifact, or it's big extensive surgery that the robot is not equipped to handle. That's when we go the non-robotic route. Another question I was asked was, is the knee replacement incision smaller with robotics, or does it allow you to cut less muscles with robotics? So the incision, is, believe it or not, is about the same size. We still have to get the implant in. So that happens. But what we do is we do certainly cause less tissue damage to the knee or the hip. We're not going into for a knee, we're not going into the intramedullary canal, so there's less blood loss. For the hip, we're not visualizing the acetabulum, which is the cup, in full detail, because we get to see what we need to see based on the 3D scan. So it does make what happens on the inside a little bit less invasive, for sure. So, recovery after a knee replacement. So recovery after a knee replacement, robotic or non-robotic. Robotic, in my mind, in my experience, just makes it a little bit quicker. But what happens is you're up and walking the very same day. Use a walker or so for a week or two till you get your strength. And then therapy is a big deal after a knee replacement. We have you go twice a week for 6 weeks to work on range of motion, trying to get that bend back. And so 6 to 8 weeks after surgery, you're walking pretty well. You got your range of motion back. And about 8 weeks to 12 weeks, you're working on strength. So all in all, I tell patients this rough timeline. 8 weeks, you're about 66% better. 12 weeks, you're about 95% better. At a year, you're about 99% better. So that's sort of the rough timeline that it takes. But knowing that everybody's different, everybody takes their own sort of course. So let's see, there's a good question on, while I understand the recovery could be quicker, can robotic replacement result in better post-surgery performance of the replacement versus non-robotics, just knee replacement? Could you have better mobility that if you didn't have robotic procedure? The main reason why that helps, I think, is robotic helps you control the intraoperative assessment. It gives you concrete numbers on where you're standing, how tight your ligaments are, when you start and when you end. And that gives us a better understanding of, okay, did we make the knee where the patient's default sort of laxity is? So it gives us a better idea of balance. And I think that helps people. The universal goal with knee replacement is trying to get it back to the same knee that you had when you were 20 years old. I'll be honest, we're not quite there worldwide with that, but we're getting very close. And little things like this, sort of get us to where we need to be. And PT is still a big deal with knee replacements, robotically or non-robotically. We want you to work with a therapist to get the bend back, because that's very important. Those first 8 weeks are crucial in allowing you to do that. So that is very important. And no PT, somebody asked that question, no PT for hip replacements. We don't routinely prescribe PT. It is purely, I usually tell patients, activities of daily living is pretty much sufficient to get your range of motion back and just build your strength back over time. Somebody asked, what's the reason for fluid in the knee? Is it only possible to cure or only drain? Fluid in the knee is the body's way of responding to the arthritis. One of the analogies I tell patients is when you have a cold, you have a runny nose. The runny nose is not the problem. The cold is the problem. The runny nose is just a symptom of the problem. Same thing when you have fluid in the knee or a Baker's cyst. These are all common things that we hear about. Those are all symptoms of the problem, not the problem itself. We can drain it, but the underlying problem still exists. So as long as the underlying problem still exists, it'll come back. It's just a matter of time. So until the underlying problems gets resolved, these are just temporizing measures. Do patients go home the same day after a knee replacement? Yes, for both hip and knee replacements. They are going home the same day these days. More and more patients, especially after COVID, nobody wants to spend a night in the hospital. So it really is not so much on the surgery, it is more on your overall medical health. So if you're pretty healthy, no significant cardiac or other issues, we'll let you go on the same day as long as your primary care doctor agrees. But if you have more significant medical issues, kidney issues, or heart disease, lung disease, we'll probably want to keep you a night in the hospital just to make sure you're okay and you're responding well from surgery in that regard. But so that's the difference. It's not really so much in the surgery itself, it's more on your overall health that determines if you can go home the same day or not. What is recovery for hip replacement? And is it helpful to do pre-surgery exercises to build muscle? Yes, it is very helpful to do pre-surgery exercises for not only the hip, but for the knee. I always tell people, the more, the stronger you go in, the stronger you come out. So if you can work on getting the strength back, then you can, you'll be better things. There's actually a good resource on the internet. It's by the AAOS, which is the American Academy of Orthopedic Surgeons. I love that resource. It's got great exercises that you can do by yourself at home. So if you Google AAOS hip conditioning exercises and AAOS knee conditioning exercises, fantastic resource. Well, it's been documented really well. It's a team of physical therapists, orthopedic surgeons, rehab folks. Everybody came together and developed this. It tells you exactly how often to do it, how frequently do it, and how to do it, and what things to do. So it's a great resource. It's got pictures on it. It's very, very helpful. I love giving it out to patients who come to see me in clinic. And really, it's a very easy way to do home therapy in my mind. And it's sort of, stuff that you can work on right away, right now. If your surgery is in a month, in a year, it always pays to get it stronger. Recovery after hip replacement is much easier than knee replacement in general. You're using a cane walker for about sort of for about 2 weeks, and then about 6 to 8 weeks, you're pretty good. That if I see you walking outside, I would not know you had a hip replacement. And pretty much by that 3-month mark, people are pretty much doing what they want to do. There's no restrictions that I impose on them. One of the common questions is people, and somebody asked this question actually, is about kneeling after a hip replacement or a knee replacement, sorry. So kneeling is actually allowed after a knee replacement. It just feels awkward or strange, so people tend to not do it. What we're now starting to do at OrthoVirginia is we're starting to involve kneeling exercises as part of early therapy for knee replacements. So when we get patients in for their post-operative therapy, we get them plugged in with the therapist right away to start working on bending and getting them to kneel on the knee early on to work on desensitization, because that's the most important thing. So it's not that you can't kneel on it, you can kneel on it, you're not going to damage anything. It just feels weird. And there's different ways to get patients desensitized, and therapy is a great sort of help with that. We also encourage patients to use foam donuts and things of that nature to help offload. Start with soft cushions, then slowly progress on to the hard surfaces, and little things like that make a big difference. Activities after knee replacement, I really don't restrict people. You can do whatever you want, anything you want, including playing pickleball, tennis. I just tell people don't run on it for too long, because you're going to wear out the bearing. But running for short distances, short sprints is okay. You're not going to damage anything. So the goal for me is, when you come to get, the goal has changed a lot, right? A goal a couple of decades ago used to be for patients just to be able to walk. But nowadays, patient population is different. Patients are getting arthritis. We're identifying arthritis earlier in life. Patients are more active, so they want to do more things. So we sort of encourage patients to get back into activities and do things that they want to do. Somebody asked the website. So the website again is AAOS. So AAOS.org is the website. So if you Google AAOS knee conditioning and AAOS hip conditioning, you'll get good exercises. And actually, you can do that for any body part. So if you have other issues like shoulder replacement, shoulder issues, you can do that for shoulder conditioning. They have exercises for every single body part out there, which is fantastic resource. I love it. Somebody asked a question I glanced over earlier, but I forgot to get to it. So they are doing robotic surgery for shoulder replacements as well. Now it's coming out. It's hip and knee are sort of the frontier, but shoulder is sort of robotic platform is definitely coming along for shoulders as well. So a question asked was, robotic knee surgery, one big muscle is laid aside rather than be cut. Is this accurate? They said it's made a difference in recovery time. Actually, it's not exactly true. Robotic surgery does not make a difference in how you approach the knee. That is an approach-related issue. Robotics has no bearing on that. But robotics does make you quicker because there is less trauma to the tissue, in the sense that you're not invading canals, so there's no blood loss. The knee doesn't fill up with a whole lot of blood because blood doesn't leak out from the canal. So there is sort of early recovery, but not necessarily because of robotic or non-robotic. For that muscle reason, that's not going to make a whole lot of difference in recovery time. An ice machine so ice is what is the key, not the ice machine, right? If you can for a hip, if you have access to ice machine, or if you already had a knee replacement and you have the machine at home and you just need to buy an attachment, feel free to buy the attachment, but don't feel obligated to buy the attachment. All you need is to really put batches of ice on that affected area, and that works equally as well. Again, the idea is to preserve your anatomy, calm the inflammation, and get you back to where you need to be. And if ice machine lets us do that, so be it. But if the bags of ice is it's all you have access to, that works just as well. So those things ice is a fantastic tool in our arsenal for sure. So thank you very much. These were all some fantastic questions that people ask. I loved doing this presentation. I love what I do. Hip and knee replacements are what I like doing. I love talking about the pathology. I love talking about what stuff there is. I love technology. So I'm glad you guys were able to join in. If you want to discuss a specific issue or question, the best way is to come meet with us in clinic. That way we can look at your own x-rays, talk to you more specifically about your own specific issue.